Good morning, good afternoon, good evening, everyone. Thank you so much for joining our ACNS ISMINS webinars today. So today our chair is Professor Li Ming, who is the Vice Chair Neurosurgery Department of Henan Provincial People's Hospital. He's also Associate Professor of the Zhengzhou University in Zhengzhou, China. He'll be joining us slightly a little bit later. And for the speakers of today, Professor Zhu Qing will be speaking on behalf of Professor Lan Qing. Professor Zhu Qing is the professor of the Department of Neurosurgery of the Second Affiliated Hospital in Suzhou University in Suzhou, China. The topic of today is the pterional keyhole approach and its clinical applications. And our second speaker today is Professor Andres M. Robiano, who is a professor of neurosciences and neurosurgery of the 𝑷𝒓𝒐𝒊𝒏𝒈 in Bogota in Colombia. He'll be talking about the minimally invasive procedures in acute cranial neurotrauma. Our discussion today is Professor Ashwell, who is the Chief of Neurovascular and Neuroendovascular Therapy Center, the Department of Neurosurgery, Faculty of Medicine, University Agani in 𝑑𝒓𝒐𝒊𝒏𝒂 General Academic Hospital in Surabaya, Indonesia. And second discussion is Professor Asmin, who is the Head and Senior Consultant Neurosurgeon in the Department of Neurosurgery, Tunku, and the Hospital of Kuala Lumpur, Department of Pediatric Neurosurgery, and the Hospital of Tunku, Women and Children Hospital in Kuala Lumpur. He's also the head of the Neurosurgical Service and the Ministry of Health in Malaysia. To moderate our session with me, we have Dr. Hui Pham, Dr. Biswa, and Dr. Atik, and Dr. Biswa. And without further delay, shall I invite Professor Zhu Qing to share to present his first talk about the pterional keyhole approach and its applications.
Thank you, Professor. And I'll share my screen. And good afternoon, ladies and gentlemen. And I'm very glad to have this opportunity to introduce the work of the neurosurgical team led by Professor Lan Qing in microsurgical of pterional keyhole approach and its clinical application. And as we know, the pterional craniotomy is widely used in exposure of the suprasellar region, just the so-called classical Yasagio approach. For skin incision, the positioning of the pterion is sometimes determined by two fingers above the zygomatic arc and one thumb behind the orbital. But the size of the head and the fingers also varies greatly among individuals. Here we introduce a precise positioning method, especially suitable for pterional keyhole approach. And on the horizontal line of the keyhole hole, there is a surface depression about 2 centimeters away from the keyhole hole, indicating the sphenoid crest. And the pterional approach used the Sylvian fissure as an anatomical corridor, which minimizes the retraction of brain lobes and can deal with most skull-based lesions, such as sellar region, anterior and middle cranial fossa, even upper clivus. The classical pterional approach starts 1 centimeter in front of the tragus above the zygomatic arc and runs along the hairline, then extends upward to the midline and sometimes to the contralateral side. And the modified pterional approach ends at the positioning of the same side of the pupil. Such a large skin incision is made to allow the skin flap to flip downwards and expose the area of the skull base. And the only bone window truly needed is a smaller part as shown in the figure, because retraction of the brain tissue can lead to brain contusion. This is a schematic diagram in a surgical atlas, shows that the skin incision is much larger and the craniotomy is smaller, and the dural incision is further reduced. The space available for opening the Sylvian fissure is only about 2 centimeters from the proximal end. Whether a smaller incision could achieve such a keyhole craniotomy, we have made some anatomical experiments and clinical application. We found that the small skin incision of the pterional keyhole approach is located exactly between the anterior and posterior branches of the facial nerve and can also avoid the injury of frontal branch of the STA. We open the skin to the fascia of a temporal muscle and pull it downwards together. At the pterion, cut the temporal muscle along the direction of the muscle fibers to minimize the injury of the muscle itself. Then we can find a H-shaped bone suture. This is the pterion. Remove the small bone flap and can see the middle meningeal artery below. After opening the Sylvian fissure, we can explore the internal carotid artery and its important branches, and the optic nerve and its chiasm. After further opening the Liliequist membrane, the proximal structure of the basilar artery can also be found. And via the optical carotid window or carotid oculomotor window, if needed, the posterior clinodal process can be removed by high-speed drill to obtain a larger space and for controlling the proximal basilar artery during the aneurysm surgery. And this is a clinical case, the skin incision behind the hairline for cosmetic consideration. Although the length shortened to 4 centimeters, there is enough space around the pterion for removal of a sphenoid crest, and the temporal muscle is opened along the direction of the muscle fibers in the direction of the sphenoid crest and separated laterally, alleviated exposure of skull base obstructed by muscle flap. The range of muscle incision is much smaller than that of conventional craniotomy, and no temporal muscle atrophy is observed after surgery in our case series, and also with minimal impact of appearance. At last, the bone flap was fixed and the skin incision was closed. And here we illustrated the procedure of craniotomy of a pterional keyhole approach, and we cut the muscle along the fibers and open it laterally. And this we can find a H-shaped suture. This is a pterion. And we use high-speed drill to do the bore hole in the sphenoid crest, and then craniotomy. After that, we use a small high-speed drill to drill off the sphenoid crest, and then open the dura. And after that, we suture the dura and use artificial dura matter, cover it, and then fix the bone window, and close the incision. And at last, it achieved a satisfactory cosmetic result. And this is the final view. And the length of the incision is 4 centimeters. The advantage of a pterional keyhole approach including shorten the skin incision to 4 centimeters and open the temporal muscle along fibers to minimize the injury to muscle itself, and burr hole on the sphenoid crest directly to decrease the loss of skull bone and avoiding damage to the facial nerve and mandibular joint. Some neurosurgeons believe that a larger incision is irrelevant, but the patient's experience is vastly different. And this patient has mirrored bilateral posterior communicating artery aneurysms. Due to the aneurysm ruptured on the left side, a larger craniotomy was performed previously to clip the aneurysm in the outer instrument. Although the approach has been reduced compared to the conventional Yasagio craniotomy, there were still excessive surgical scar and the temporal muscle was atrophied. Then she requested a keyhole surgery for contralateral side aneurysm in our department. The post-operative feeling is that there is a huge difference between her two procedures, and the second surgery brings both physical and mental pleasure. The pterional keyhole approach also alleviated the removal of basal ganglion hypertensive hematoma. A surgical corridor can be created in insula by limited but adequate opening the Sylvian fissure. This is the final picture and after the subdural procedure. Another example is an anterior colloidal meningioma. The tumor was removed totally via a pterianal keyhole approach with the intact over adjacent arteries and nerves. This is a video record for this patient, and the up was the preoperative image. The lower is postoperative, and showed the total removal of the tumor. And we use the pterianal keyhole approach. And after open the Sylvian fissure, we can find the tumor. And we use the QSA to decrease the volume of the tumor. And here we found the MCA and preserve it carefully and remove the tumor piece by piece. And here we can find the bifurcation of the internal carotid artery, and we continue to use the QSA. And the posterior projector tumor, we removed it carefully. And the QSA is a very useful tool for the resection. After that, we remove the ACP, use a high-speed drill, and resect the tumor in the axilla region. And we preserve the internal carotid artery and the ipsilateral optic nerve. The last one of the tumor was removed, and we can find the preserve of the ACA. This is the final view after the removal of the tumor, and this is the keyhole craniotomy. So the favorable factors for pterianal keyhole approach including skin incision within the hairline, and the neurosurgeons familiar with this approach, and the lateral observation of dorsal internal carotid artery, and adequate exposure to intracellular and upper clival region. And here we will illustrated a large craniopharyngioma. This tumor was located in the supracellular region and the upper clival region. And we also use a pterianal keyhole approach. And after open the Sylvian fissure, and we decrease the cystic portion firstly, and then we use several anatomic window to resect the tumor. This is the oculomotor nerve, and we resect the tumor and preserve the nerve intact. And this portion is located in the dorsal part of the internal carotid artery and can be safely removed in this approach. And from the carotid and the oculomotor space, and we resect the tumor just in front of the basal bifurcation. And here we can find the trunk. And this portion is in the upper clival region. And we also removed it piece by piece. And then we use the carotid optical window and to resect the original point of the tumor. This is a pituitary stalk preserved intactly. Then endoscope was used to confirm the total removal of the tumor. This is upper clival. And this is the final view for the approach. And however, there is also some unfavorable factors for such keyhole approach. The first is needing to drill off the sphenoid crest epidurally, at least to the meningeal orbital band. The second is compared to the subfrontal approach, the poor exposure over the third ventricle anterior posteriorly, and a far length to contralateral structures. But according to the concept of keyhole neurosurgery, a precise preoperative planning leads to a successful keyhole surgery. So we should carry out individual keyhole surgery based on different patients. And that's all. Thank you very much for your attention.
And thank you so much, Professor Zhu. So maybe shall I invite our discussion to come in this lecture first? So shall I invite Professor Ezra for your comment?
Okay, thank you, Liu. Thank you for your great presentation, Professor. And I just want to give comments and also ask one question for you. Yes. Yes, I also use this keyhole approach for some pathology in the brain. And I use also supraorbital approach despite the keyhole paternal approach. So what do you think about the supracellular tumor between the supraorbital approach compared with paternal keyhole approach? In my experience, I always use supraorbital approach for supracellular tumor. Yeah. What do you think?
Thank you, Professor. A very good question. And in our opinion, the supraorbital keyhole approach, the biggest problem is cosmetic consideration. And in the early time, we do the skin incision just in the eyebrow. But after 5 years to 10 years follow-up, we found the cosmetic result was not so good. And many people have some there has the atrophy for the skin incision. So at that time, we changed our planning for the supraorbital keyhole approach. We use a larger incision in the hairline, but the bone window was small, just as the supraorbital keyhole approach. And for the resection of the tumor, and the pterygium keyhole approach can give us a more lateral view for the tumor, especially for the dorsal part of the internal carotid artery. And the supraorbital keyhole approach can give us the view just more anterior-posterior direction, especially for the suitable for the tumors grow into the third ventricle. So before the operation, we will study carefully for the image of the patient, the MR, DSA, or CTA, to determine whether the tumor's direction part. So if the tumor was grows to the third ventricle, we will use the supraorbital keyhole approach. But if the tumor just as showed in my PPT, the craniopharyngioma, we prefer to use the pterygium keyhole approach to use the carotid optic window to resect the tumor and the direct observation for the pituitary stalk to preserve it. So I think for the difficult patient, for the different patient, and we will plan it individually based on the characteristic of the tumor. Thank you, Professor.
Okay, thank you. My second question, do you have experience using this approach for aneurysm surgery?
Yeah, we do a lot of aneurysm surgery in this keyhole approach, and we found maybe the conventional esophageal craniotomy maybe can be placed by the pterygium keyhole approach nowadays. Yeah, especially even the patient in the aneurysm subarachnoid hemorrhage.
Okay, thank you. I think your explanation is very important for
Yes.
young neurosurgeon, yeah, to use this approach for some pathology in the brain. Thank you, Dr. Ben.
Thank you, Professor.
And how about Professor Azmi? Any comment from you?
Okay, thank you, Ben. Thank you very much for your presentation. I'm actually learning a lot because you managed to describe your technique right from beginning, the basic concept, the keyhole concept, and you show all the anatomical window, the optical carotid window, subchiasmatic. You shows even you can drill the clinoid to get better access to control the basilar artery. This is a very good, and the anatomy also very clear. And also you show the advantage of this technique where you can use very small incision, but I saw some of the incision actually within the forehead. Maybe that for selected cases, or it can be hide behind the hairline, because aesthetic in that particular place is a very important. I believe that you have shaved a little bit, then make sure that the incision not in the forehead and it will be hidden by the hairline. That is very good, because if you make incision and visible, then it's defeat the purpose of minimally invasive and aesthetic. And the other thing is you also shows that this technique actually very fast, because you just need to split the muscles along the longitudinal fiber, and then you make a very good craniotomy and you go straight to the target. But my concern is in the presence of swollen brain, for example, in acute ruptured aneurysm, when there is an edema, or you can have a tumor which cause compression, because in this keyhole approach, the most important thing is to have a good brain relaxation, and also to have a very good CSF release. Then you can, because your window is small compared to standard craniotomy. So what is your advice for especially the young generation, whether this technique keyhole should be selectively used for certain cases, and what type of cases that in your opinion may not be a good for the beginners unless you really master it? Thank you.
Thank you, Professor. And for the ruptured aneurysm, this is also a problem. And in our hospital, for the patient with acute subarachnoid nodal hemorrhage, and if the patient associated with hydrocephalus, we will put the EVD before the operation. And if the patient is not associated with hydrocephalus, before we perform the craniotomy, we will perform the lumbar drainage. And during the operation, and we release some CSF to relax the brain to alleviate the aneurysm clipping. This is a very effective method, I think, because even after the operation, we will use the lumbar drainage to decrease the bloody CSF several days. I think this is a routine procedure for many institutions. So, and for the young neurosurgeons in our department, we did not training them perform the conventional esophageal craniotomy firstly, and we training them do the keyhole craniotomy firstly, because we have the technique supported by Professor Lan Qing, and for some for many patients, we based on the minimal invasive concept, and they were not needed to the more larger craniotomy, and we will do the more minimal invasive keyhole craniotomy for many patients. So I think the training concept is very important for the young neurosurgeons, and this is nowadays very important. Thank you, Professor.
Yeah, thank you very much. Very good explanation and very good advice to young neurosurgeon. My second question is, what about when we have a tumor, for example, suprasellar with extension into the third ventricle? Because most of the time you can use the window from the lamina terminalis, but with the small opening, do you find any difficulties, especially in a craniopharyngioma with a calcified component? Because if you have a cystic component, it's okay, but when you have a calcified component and it's going higher up, so do you find this technique has limitation, or you have a tricks to overcome this issue?
Yes, and for the tumors, some larger tumor and grow into the third ventricle, I think the pterygoidal keyhole approach is not so suitable for that, because even we open the lamina terminus, and we also can't directly observation for the tumor and remove it successfully. Sometimes, and we prefer to use the subfrontal approach, just as a 𝒓𝒐𝒏𝒂 keyhole approach, and assisted by the endoscope to remove the tumor.
Okay, my final question is, do you have any instance where you have to convert your mini toroidal to a larger incision? And if there was, so what kind of cases that you encounter this problem?
Yeah, and during the preoperative planning, if we are consider the tumor is larger and we can't use a single approach to remove it, and maybe we will do some larger craniotomy. For example, a more larger craniopharyngioma, that is a classical example, and we will do a larger skin incision, just like the Yasagio craniotomy skin incision, and then we use the cranial keyhole approach craniotomy, extending to the subfrontal part. Maybe we will do the bone flap to the maybe 6 to 7 centimeters in the length to deal with such difficult position. Thank you.
A very nice presentation. Well done, well done. Thank you very much.
Thank you, Professor.
Yes, and I would like to ask Professor G some questions about, because I also have started using this technique of the pterional keyhole, or so-called the mini pterional approach for the intracranial lesion. I would like to, first of all, is about the skin incision. So in some patients, so I do encounter patients have a thick temporalis, very thick. So because I think the whole idea is to expose the keyhole so that you could drill the sphenoid ridge so that you could split the sylvian. But some patients, they do have very thick temporalis, and then the retraction will be quite great, quite big if you need to expose the keyhole. And how would you deal with that? This is my first question.
Thank you, Professor. And for different patients, and we can find that sometimes the patient's headline was very high, and the patient maybe we think a 4 centimeters long skin incision, we can't turn the flap into the skull base. So this time we will prolong the incision, and to do the skin incision to expose the pterion, and we think during our craniotomy and drill off the cranial sphenoid crest is most important. At least go to the meningeal orbital band.
Yes.
This is at least. So, and after that, we open the dural. We can from the along the sphenoid crest to the carotid cyst to release the CSF.
Yes, and but we will cut the muscles if it's too thick.
No, we don't cut the muscle, and we just to separate the muscle just along the fibers and laterally.
I see. So yeah, you're right that because if you observe the skin incision, sometimes I can see the case that you illustrate the hairline of that lady is like a zigzag. Zigzag. I think this is the best for the mini pterional because the anterior limb, the anterior end can come to very anterior because you have the zigzag shaped. So the anterior pointer can come to very inferior. For example, let's say my hairline, so might be a little bit marginal for this approach because I do not have that shape and slightly posterior. So I totally agree with your opinion that we will need a greater incision for that. So my second question is about the technique of the drilling of the anterior clinoid in this approach. So I do try to drill the sphenoid ridge, but do you have experience in doing the extradural canaldectomy with this approach? Because as you said, you can expose the middle meningeal brain, but the middle fossa may not be. You may not expose the middle fossa so much so you can peel off the V1 and V2. So will that cause a problem with the extradural approach, extradural canaldectomy, because of the limited exposure?
Yeah, in our department, we seldom do the extradural approach for the commonest tumors, because in our opinion, and the subdural procedure is enough for most lesions, such as aneurysm tumor and so on. And we can also find in the literature, and there are some experts do the epidural removal of the ACP, and I think it was too large. It was too large and more injury for the patients. And we can also drill off the ACP subdurally, and this is enough, I think, because from the epidural part, this is I think the injury was too large. Thank you.
I see. Thank you so much.
Thank you.
So is there any other questions from the floor? Any comments from Professor Kato about this approach?
I think it's thanks so much. So it's a wonderful approach. So I think it's a time to teach YNS about this concept, and of course, Dr. Azmi and Asra, that they can use the endoscope. I think maybe combining with the endoscopic with the invasive approach. I think, of course, the Lantini is expert of such a wonderful approach, and he can do so many microvascular compression cases. I know. Anyway, thank you very much.
Thank you, Professor.
Thank you.
And thank you so much. So any further comments from the floor about? So if not, I saw Professor Li Ming is here, so he's supposed to be the chair. Maybe he could chair our second session by Professor 𝒏𝒂. Professor Li Ming. We cannot hear about your voice. Yeah, maybe Professor 𝒏𝒂, maybe you can start sharing your screen.
Hello, good night for you. Okay, thank you so much. I will be starting to share my screen. Do you see my screen now?
Yes.
Okay, perfect.
Yes, we can see your screen. So
Okay.
you can start your presentation.
Okay, so I will start. So thank you so much for the kind invitation. Thank you, Dr. Cato, also to Dr. Lin and all the chairs and moderators. I think this is a great opportunity to share from the Neurotraumatology Committee of the World Federation and also from the Neurotrauma chapter of the Latin American Federation of Neurosurgical Societies. All the work that we have been doing locally here in Latin America. So I'm going to speak briefly today about minimally invasive procedures in acute cranial neurotrauma. So I do not have any conflict of interest. Some of the work that I will be sharing is part of some of the protocols that we have been developing with the NIHR Global Health Research Group in acquired brain and spine injuries. It's a project that is supported by the University of Cambridge and funded by the National Institute for Healthcare and Research from UK. And is developed in our center, that is Meditech Foundation. It's our research centers locally, where we manage one of the few international fellowships in neurotrauma and global neurosurgery right here in Cali, Colombia. So we all know about the importance and the big development that the minimal invasive surgery have in neurosurgery. I just want to share these two interesting articles from the 1990s regarding the first concepts of applying minimal invasive surgery in neurosurgery. One is from the British Medical Journal, and they were describing initially the procedures performed with stereotactic, and also how at that time, especially biopsies and craniotomies were starting to be performed following these systems. And also a really good review from one of my really good friends, Professor Jeffrey Rosenfeld from Australia, about the application of these same approaches, and also talking a little bit more about neuroendoscopy at that time and how was initially being applied, specifically in pediatric neurosurgery. So I think since more than 30 or 40 years ago, these aspects have been entering into the neurosurgical management. Then this is 10 years after. This is one of the minimal invasive neurosurgical books from Dr. Black. And it was a specific chapter related to minimally invasive procedures in TBI, also with one of my friends, Professor Bishan Arabi, who was the chair of neurotrauma at the CHOP Trauma Center in Maryland, with a lot of experience in war areas, management of patients. They were pretty focused on monitoring systems. So most of the chapter is describing monitoring processes for brain oxygen tension, also for ICP monitoring, and some discussions related to external ventricular drains. So right after that, 5 years later, this is another article from Professor Liu Baiyun from China, speaking directly about the application of minimal invasive surgery in TBI also. And he was very focused on the surgical techniques and how to take care of the different tissues in the head. And he mentions specifically that when selecting TBI surgical options, physicians should strive to achieve the best therapeutic effect with minimal surgical trauma. So I think these are really interesting analysis of how many of these techniques were integrating, and also how to combine that with taking very technical aspects of the surgical procedures in this type of patients. We all know that Now, there are a huge trend about using endoscopy, especially for repairing CSF defects and also for cranial reconstruction, mostly in children, but also in adults. This is a really interesting study, also from China, comparing open craniotomy with transnasal endoscopy for surgical repair of CSF leaks. They propose a specific algorithm where small defects of less than 1 centimeter can be managed with the transnasal endoscopic approach. And when these defects are larger, more than 1 centimeter, they suggest to go for open craniotomy. So all these process have evolved, and I think at this moment the present structure to define and consider the minimal invasive surgery in TBI is divided in two big groups. The first one that is dedicated for acute traumatic brain injury patients that include mostly the ventricular drainage with the ventriculostomy, the cisternal drainage and washing cisterns with cisternostomy, the hematoma drainage, and then the vascular management of acute traumatic vascular injuries. And in the non-acute TBI stage, these techniques are very often used for CSF leak repair, cranial reconstruction, post-traumatic brain abscess or brain empyema drainage, chronic subdural hematomas drainage, and also for endovascular management of post-traumatic vascular injuries that are not urgent. So focus on this structure, I'm gonna center my talk today in the acute TBI cases, and I'm gonna take out the endovascular management and will be very centered in the three topics that remains, that are the ventricular drainage, the cisternal drainage, and the hematoma drainage. So we all know about the importance and the common aspects of the ventriculostomy. Is one of the more frequent procedures performed worldwide in TBI patients and in non-TBI patients also. Additionally to that, we understand that if we go globally, procedures related to traumatic brain injury are the most common ones performed either in LMICs and high-income countries also. So for ventriculostomy, we understand that neuronavigation and a stereotactic approach are routinely used in many practice. Intraoperative imaging have been really useful right now for avoid complications. However, as was mentioned by Dr. Juha Hermanniemi, it does not hurt to study the neuroimage very carefully to identify critical landmarks, and the preoperative planning and mental conduction of the entire procedures should also include ideas on unforeseen findings and occurrences. So this is the art of dealing with all these issues that comes with the experience. I regularly give a talk in some of the courses that we do globally related to neurotrauma management. So what to do when you need to put an EVD and you don't have a neuronavigation system, when your neuronavigation system is broken, or as it happens in many areas, especially in Latin America, Africa, and Southeast Asia, that sometimes the neuronavigation is not always available due to many different barriers. So it has been a study about putting these systems when you have image guidance. Obviously, it decreased the amount of complications. There have been some studies doing the comparison from freehand insertion versus neuronavigation. And it's pretty obvious that when you have a navigation system, you avoid all these misplacement. This is one of the studies from the Barrow Neurological Institute regarding the safety and accuracy of bedside external ventricular brain placement. And they divide the complications according to the position. They divide 3 grades of positioning for the catheter tip location. The grade 1 is optimal and adequate. It will be in the ipsilateral frontal horn, including the tip of the third ventricle. The grade 2 is at suboptimal positioning, but in non-eloquent tissue, generally contralateral frontal horn or lateral ventricle or the corpus callosum or at the interhemispheric fissure. And the third one is the suboptimal in eloquent tissue that regularly comes to the brainstem, cerebellum, internal capsule of basal ganglia, thalamus, occipital cortex, or basal system. And in the study that they performed, the placement of the catheter tip was grade 1 in 77% of the patients, grade 2 in 10% of the patients, and unfortunately, grade 3 in 13% of the patients. But the most important issue was that the highest rate of suboptimal placement was observed in the trauma subgroup. So many patients in the acute settings in trauma are the most exposed to mispositioning or misplacement of the ventriculostomy. And we already mentioned that this is a very frequent procedure that is performed globally. And unfortunately, sometimes this procedure is left for the more junior doctors, and in this case, sometimes the more junior residents. And because what we had been mentioned, according to the level of skills that are required, sometimes they do not have the skills or the experience to deal with this condition. So we have in the picture some of the misplacement and mispositions tips, and it's terrible when you have, for example, that in the basal ganglia or the brainstem. So regularly the approach, we all know that the most common one is the Cocker's point, that is approximated 3 centimeters off midline, and it should be 1 to 2 centimeters anterior to the coronal suture. But we all know that sometimes the coronal suture is not palpable if you are doing this by freehand. And one of the other points that has been suggested and is more structured, more elaborated, is Gaillard's point that was proposed by Dr. Jean Gaillard from the Brain Trauma Foundation when he develops the famous system for advancing the ventricular catheter. This tripod is suggested to be positioned 10 centimeters from the nasion over the sagittal suture and then 3 to 4 centimeters laterally of the midline. So the references are pretty similar to the Cocker's point to guide the catheter, but this has been studied neuronavigation and one of the most accurate entry points for leaving the ventriculostomy. So from our experience, we really recommend to use more Gaillard's point, even in very compressed or slit ventricles in TBI patients. This is a common situation that sometimes avoid to use the catheter placement. I'm gonna present briefly this video from one of our recent cases where we use the Gaillard's point in a TBI case that have very compressed and slit ventricles. So we locate the positioning. In this time, we are looking for the nose. Then taking the nasion, we already have the 10 centimeters. We are looking for the internal auditory position in order to introduce the catheter. We look for the internal canthus as is described in the general technique. And then we just give the orientation for the ventricular placement around 5 to 6 centimeters, and then we obtain the CSF without any problem. So this is, as I mentioned, one of the most useful points of access, even in those patients that we consider sometimes difficult if we don't have navigation system or if we don't have a stereotactic guide or if we don't have endoscopies. We all know that now there are some very thin endoscopies that can be used for ventriculostomy procedures. So the other procedure that is considered a minimal invasive approach one is the cisternostomy. We all know that it's a procedure that is becoming more used in traumatic brain injury patients, especially in the Asian region. The procedure looks for doing drainage of the cistern CSF, especially at the optic carotid cistern. So it requires a pterional approach, mini-pterional approach. In order to do this, regularly can be performed with loops or with microscope. So the principle is based on the description of the lymphatic impairment and what is have been mentioned, the chief edema. And there are some cases that beneficiate the most for this procedure, especially the cases that have like an important amount of post-traumatic subarachnoidal hemorrhage at the cistern level. And the idea is that if you wash the cisterns, you avoid the possibility that the CSF become in an opposite or reverse flux through the virtual Robin spaces, generating increased brain edema in TBI patients. So more recently, we know this is a movement that has been driven by Professor Cherian, who actually is working in India. And in one of the last discussions that we have in one of the ICRAN meetings, actually in India, he was discussing about proposing moving the cisternostomy to different categories approach, where you can have the level 1 that is just the sylvian fissure opening and washing, the level 2 that is the optic carotid cistern opening and drainage, that is the traditional one, and the level 3 that is the more advanced that include opening the Lilliquist membrane for opening and drainage the prepontine cistern. So it seems like this technique is evolving, and in that evolutionary process, it has been tailored for different type of cases, and this is still under evaluation. There have been becoming more and more studies recently, and I think it's one of the minimal invasive procedures that will be more used in this moment and in the future for traumatic brain injury patients. We also have the minimal invasive hematoma drainage. So it can be done either by endoscopy or by open technique, with also keyhole approach like the pterional, the pterional one. Sometimes also the supraorbital approach. And these are some examples of this type of management for brain contusions mostly. This is a group that has been studying more and more this type of approaches in Brazil. So we have some cases here also with minimal invasive procedures. So you can see here how with these small incisions and conventional approaches that are regularly used for vascular procedures can be managed these traumatic brain injury patients. So this is some of the examples of the articles from led by Dr. Rodrigo Faleiro from Belo Horizonte in Brazil, who have been working with this technique. Also some of the friends that are working in Sao Paulo and in Manaus have been working with this technique, mostly with endoscopes. This is one of the case series from Japan, also showing their experience with endoscopic aspiration of cerebral contusions, especially the ones that have delayed progression. So we have many of the cases very well explained and details into the evolution process. And one of the important issues here that will be open to the discussion in the comments and question session is how to define a minimally invasive neurosurgical procedure in the acute TBI, especially in the area of damage control in neurotraumas. We all know because of the lessons learned from the more acute cases, especially from the military settings. We have been evolving in many regions of the world to do big surgeries, especially with big decompressive craniectomies, and how this is like the most common scenario for severe TBI cases worldwide. So I think fine-tuning when to use the minimal invasive procedures and when to go for these big craniotomies and craniectomies is something that we have been looking more and more into many of the exercises that we have performed for developing different set of consensus and guidelines in traumatic brain injury. So this is one of our review articles with many people that have been working with this type of patients for damage control procedures, especially in military areas and also from the groups from Latin America. And I think definitely the key aspect will be a more recent concept that we have been trying to promote that is called the intracranial compartment syndrome that can be evaluated even in the acute setting. This is a picture of some of our trainees, our fellows, and international residents that come to our center to be training all these different systems. So this is one of the recent articles that we wrote with some colleagues from Latin America related the pathophysiology and the concept about the intracranial compartment syndrome. So the main idea is that if we follow the regular trends of ICP monitoring, of invasive ICP monitoring, regularly based in the ICP value, and sometimes not very often into the waveform analysis for understanding if the patients still have compliance or not. But now, with many of the non-invasive systems, we have in the picture actually at least 4 of those systems. We have the non-invasive system for analyzing the ICP waveform that come recently into the market. We have been working with that system for the last 3 years. In the bottom of the picture, you see the output of the system. So you see clearly how P2 is over P1. That means that the compliance is lost inside that school. We also perform the pupillometry in order to evaluate the contraction velocity in both compartments, in the supratentorial at the right level and the left level. We also perform optic nerve ultrasound in order to measure the optic nerve diameter. And we also perform transcranial Doppler in order to evaluate the pulsatility index and also the flow velocity since the emergency department. And with the combination of these different systems, you can understand very easy in what part of the compliance waveform and also in the pressure volume curve, it is the patient. So if the patient is already with some remain of compliance or not. And all this obviously it's improved when it's analyzed in combination with the CT, because you can see the primary injury and also combine that, understanding how the intracranial compliance is performing. So definitely it's not just the primary injury. And this is how it is how the injury is affecting the compliance, the oxygenation, and which resources you have to manage the patient. Because as much resources you have for advanced critical care management, evaluation of the oxygenation of the brain, then you have possibility of being less aggressive, maybe less invasive, and have the opportunity to following very well the patient. But if you do not have too much of this technology, definitely you need to be more aggressive, thinking in the possibility of really avoid complications. I think the actual approach that we have for managing many of these patients is to act very late when the patient already has been deteriorated or is showing signs of herniation. And what is happening with many of these non-invasive systems is that you are detecting small changes in the school before the patient gets the complications. So I think that's why this is very linked to disability and mortality, because if you act before you have the complications, then you're going to have more possibilities of having a good outcome after your management. We are all familiar with this classification proposal. This is the British Neurological Surgeons classification for going more in detail about the different type or subtypes of primary injuries and how the combination of many of these different ones can allow us to go a little bit more precise and personalized in each one of the cases for the surgical management. And I think combining this type of interactions of the analysis of the primary injury with all this concept of the non-invasive systems and also the intracranial compartment evaluation, we are going to have the possibility to really understand when the non-invasive procedures will work better in order to avoid complications in these patients that regularly have severe cases. Just to finish and give a space for many of the questions and discussions, I just want to put you in this specific case. We have this patient that have a severe head injury. And if you go over the primary injuries, you have subarachnoidal hemorrhage, a little bit of intraventricular hemorrhage. You have a brain intraparenchymal lesion, and also you have a little bit of midline shift in that side. The question is, how are you going to approach the management of these patients? You have several surgical options. You have less invasive, more invasive. You have minimal invasive, and from those, you have different options. So I just want to put you in these two contexts. The first one is you have this type of primary injury, but you have compliance present in both supratentorial compartments. The P1 is bigger than P2. You have normal optic nerve diameter, less than 6 millimeters in both supratentorial compartments. You have a normal transcranial Doppler with a pulsatility index less than 1.3, with a flow velocity more than 20 centimeters per second in the middle cerebral artery in both supratentorial compartments. And you have an automated pupillometry normal range with an MPI more than 3 or symmetrical maximum contraction velocity in both supratentorial compartments. So if I have a patient with this type of image, but I have all those evaluations in normal levels, maybe I can go very precise with a minimal invasive neurosurgical approach for this patient. Maybe just left a ventriculostomy, or maybe this is the type of patient that we beneficiate the most for a cisternostomy. And also I can combine that with maybe an endoscopic drainage of the contusion. And possibly that can be enough for managing this patient. But if I have this case, and since the emergency department, I detect that this patient have at least in one of the two supratentorial compartments, probably the left supratentorial compartment, a compliance that is absent where P2 is bigger than P1, or an optic nerve diameter in an abnormal range, more than 6 millimeters, or a transcranial Doppler with an abnormal values, pulsatility index more than 1.3, or a flow velocity of the middle cerebral artery less than 20 centimeters per second, or an automated pupillometry with abnormal values with an MPI less than 3, or an asymmetrical maximum contraction velocity. As I told you, probably most of them will be in the left supratentorial compartment. These patients, this patient maybe in a more precise way or in a more personalized way need to have a more aggressive approach with a bigger craniotomy, or maybe including, why not, a decompression. So I think this is something that we have been working on. It requires a lot of work globally. I think we are now starting at least 3 trials. That this is an open invitation for the people who is interested in this type of management of patients in order to understand better how we can go over that precision type of medicine. Fortunately, we published a few months ago this consensus that was the international consensus for non-invasive ICP monitoring, especially when invasive systems are not available. That will be more focused for LMICs, but also we understand that even in high-income settings, there are so many places that do not have early access to invasive systems for evaluation of the compliance. So with this exercise, we have been proposed some algorithms for using all those systems that I just mentioned in order to define when a patient is at risk of require more aggressive management, even as a secondary procedure in patients that already have been admitted to the ICU, or even as a primary procedure in patients that still remains in the emergency. And additionally, just to finish, I want to invite you all. We are going to have a consensus about when to use and how to use and the indications of all these minimal invasive surgical options in TBI. It will be held in Machu Picchu, Peru, in November of this year. It will be hosted by the Peruvian Neurosurgical Association meeting, and it will be award supported by the Neurotraumatology Committee of the World Federation. So for the people who is interested in this type of procedures, you are very welcome to participate and develop a useful technical document that support guidance for taking decisions over many of these situations in our patients. So thank you so much.
Thank you so much, Professor Wobiano. Maybe I shall invite our chair, Professor Li Ming. Hello, Li Ming. Can you give some...
Can you hear me?
Yeah, you're audible.
Yeah.
Yes.
The presentation is good, very good, excellent presentation. Actually, you are the first Colombian neurosurgeon I met for the time. So yeah, there's some question on the panel. Some people ask good evening. What's the time for endoscopy evacuation of hematoma? Within 24 hours, does it affect the success of the operation? What's the best time for the endoscopy?
Hi, thank you. I think this is a really interesting question, Professor. And definitely, if you follow the discussion that we have been presenting, as early as possible, but I think the most important issue is if the patient really will be having enough with that minimal invasive procedure. And I think now we are moving into that precision medicine approach, where will be additionally to the CT image in order to take the decision and maybe the clinical condition of the patient, to have an additional information that in this case can be based according to the Brussels consensus that I just present in at least 2 of the 4 systems that I described. The most common ones that are easily obtainable in many situations are the ones related to neurosonography. So if we only have a echography system or an ultrasound system, we can perform at least 2 of the 4 that will be the optic nerve ultrasound and the transcranial Doppler. So if we have these 2 tools, we can define easily if that patient will have enough with a drainage with the endoscope. And as soon as possible, if we obtain normal values and we understand that that patient is not under a compartment syndrome, maybe if we do a faster procedure, early procedure, the patient will avoid complications. So because we are tackling specifically a factor that can increase the brain edema just because of the normal procedure of degradation of the red blood cells inside the brain parenchyma. So I think that that will be something very useful. I think you are muted,
Professor Asura, are here?
Okay,
Prof,
thank you.
yeah,
Thank you, Professor Mingli.
yeah.
Thank you, Professor Rubiano. Nice to meet you.
Nice
Yes,
to meet you.
yeah. Very interesting topics and presentation. Yes, we are Indonesia. We have many cases of trauma, yeah. And until now, most of our neurosurgeon, young neurosurgeon, doing the treatment of neurotrauma with the classic procedure, always big opening and decompressive. This is our usual manner until now. So I think your presentation will give us, a new idea and a new knowledge about this. And you show me that, yes, we need some facility to perform this procedure. Yeah? And I just want to ask you one question about the ventriculostomy and cysternostomy. Yeah. What do you think? Do you think that ventriculostomy can replace ventriculostomy for such kind of trauma cases? And in your institution, do you perform cysternostomy, and how you do it? Okay, thank you.
Okay, that's a great question. I think we are going to have opportunities to discuss many of these issues in person during the Surabaya ICRAN activity. I think that will be really great.
Yeah.
So definitely in that order of the discussion about precision medicine with TBI, I think there are patients that will beneficiate from ventriculostomy, and there are patients that will beneficiate for cysternostomy. Regularly, if you want to drain CSF from the ventricle, you are gonna be working only with around 30% of the total CSF of the patient. And if you are gonna drain the cisterns, you are gonna drain at least 60% of the CSF of the patient. So this is something that it's something to be taken into consideration. Additionally, when you have all these lobar or brainstem post-traumatic subarachnoid hemorrhage, it will not be possible to wash or drain that from the ventricle. So you really need to do that at the cistern level. So I think the cysternostomy will be useful in some cases, not in all the cases. And what we have been doing in our personal experience is that we are working with that as a coadjuvant during some procedures. For example, we are combining in some patients decompression, and during the decompression, we do the cisternostomy. And as a unique procedure or a long procedure, as I mentioned, it will be beneficial in patients that have normal values or even just one abnormal value of some of the non-invasive monitoring system and have a lot of post-traumatic subarachnoidal hemorrhage. So what we are doing is generating or decreasing the possibilities that these patients are going to have more load of pro-inflammatory processes for the next coming days. We all know that all these patients have the possibility to develop the cytotoxic edema in the first 4 to 5 days. The peak of that edema will be around day 5. But if you have additionally the chip edema because of the important amount of subarachnoidal hemorrhage, then these patients will not be allowed to be managed only with regular therapy for cytotoxic edema. So it's something that we need to evolve also with the persons who work with us as a team, especially in the ICU level, because not all the patients will beneficiate from hyperosmolar therapy. Not all the types of edema will be managed by hyperosmolar therapy. And that's another topic that at some point will be interesting to be discussed, and it's totally linked to this. And we now consider that we have at least 7 different types of edema, and each one of those types of edema have a different type of treatment. And we need to move from the traditional concept of only the cytotoxic and the vasogenic edema, and that's it. So definitely the cisternostomy will work in some cases. We need to understand very well which cases will benefit from that. And this is a really interesting topic. As I told you, you are all welcome to this discussion that we are going to have for the consensus.
Okay. Thank you, Professor Briano, and see you soon in Surabaya. Yeah, for next August.
How about the Professor
Thank you. Thank you.
Alias?
Yeah, thank you, Prof. Lee.
Yeah.
Okay, thank you, Prof. Lee. Rubiano, I enjoy your presentation very much. I think this is a very eye-opening talk to me because you have expanded a minimally invasive concept to trauma. Because I still remember when I was still training, or even now, we always tell our juniors or our young neurosurgeon always everything big in trauma, you know, trauma big, open big, and so on. And suddenly how you want to put something small in a big things. So in my country, trauma used to be the highest cause of death, perioperative mortality. But since 5 years ago, stroke taking over. So we implement both MIS in other things as well. So in my own experience, I have done endoscopy in acute trauma in a gunshot wound in a child. So we use a navigation CT guided, and we managed to use this concept because you can use the trajectory, because gunshot wound form a cavitation. This cavitation become a preformed space that you can use the endoscope, but only for 1 or 2 cases, because in gunshot wound the brain are very swollen. But in chronic cases or later, we have use minimally invasive technique, especially when you have infective hydrocephalus. Post-traumatic hydrocephalus, sometimes they are in a severe form, then they develop meningitis. Sometimes the wound is bad and develop pyogenic ventriculitis, or even just meningitis with a lot of slough and high protein. So we use endoscopic lavage. So we go and wash and replace the contaminated CSF with a new artificial CSF that will help to promote the recovery, clear the CSF if the patient needs shunt. So the shunt survival is also prolonged, and also some cases, you know, have a better outcome. So I have 2 questions that is to you. Number 1, I saw in one of your presentation, you show the indication of the endoscopy in removal of the contusional hematoma. So what is the timing, the best timing to use this endoscope because the hematoma need to be liquefied. Then easy for you to use the scope. And how big the wound, because contusion hematoma, the hematoma is very superficial. So mean you cannot make a small opening. You have to make a quite a big opening. So can you further explain, Rubiano?
Hi, Darius. I think that's a very important comment that you made. As we mentioned, for the non-acute conditions associated to the TBI patients, as you mentioned, the hydrocephalus, the infections, it will be very useful to use the endoscope. And definitely, according to the works that have been doing, especially as I mentioned from the Brazilians group, they go regularly for a small procedure using mostly pterional approach for draining the contusions in the first 24 hours. They regularly follow that principle that we mentioned, that is, you need to decrease the amount of tissue that will generate more edema in the coming days or in the coming hours, or you are almost preparing your patient for have a lower load of injury for the next coming days. Using the endoscope, I think you have a window of around 48, 72 hours, as we mentioned, because the peak of the cytotoxic edema will be around day 5, day 4. And after that, the vasogenic edema will come, especially surrounded those areas. So if you take this bleed, you avoid the vasogenic edema that is going to start on day 5 or 6. So it's all like preparing your patient for avoid complications for the incoming hours. So that's something that you need to take into account. And as I mentioned, this need to have more studies. And, you know, from areas like Latin America, Asia, we are going to have the majority of patients. So doing studies in our regions will be pretty easy because we have the patients. What happens sometimes, especially in other regions of the world, is that they do not have all that amount of patients that we have for trauma, especially.
Okay, thank you. Well explained. My second question, recently I attended a congress, then someone mentioned about the intracranial pressure monitoring, just using a special kind of sensor apply on the head without using any intracranial probe. So is there any recent development about this thing, and how soon we can use this technology?
Yeah, as I mentioned, we are using that technology almost 3 years ago. The system is a system that initially reproduce the ICP waveform. So we regularly use in ICU both techniques. We use the non-invasive since the emergency department, but we continue using that at the ICU. So we have both lectures, the invasive waveform and the non-invasive waveform, and they are pretty similar. So what they are doing now is trying to also calculate an ICP number for that. And it's really interesting because traditionally the ICP number have been managed, you know, for the last, I don't know, 50 years or something like that. And I wrote an article like in 2022 regarding moving beyond guidelines, because I think the ICP number will be less and less useful, but this is very difficult to understand because we have been changing paradigm for the last 50 years. So I think saying now that the ICP number in TBI is not as important as the ICP waveform analysis, it's something that, you know, is difficult, because if you take any guideline now, if you have any guideline or consensus that has been published, all are driven by the ICP number. What we have seen in our practice with all this type of integration of invasive plus non-invasive is that the non-invasive systems sometimes are more sensible and they detect the loss of compliance before the ICP number change. And as I told you, sometimes when the ICP number change, it's very late for the patient or it's too late for the patient. So definitely all these non-invasive systems will be very useful, especially for areas that do not have too many resources, but also in areas that have the resources, because it can be started from the very beginning before the patient arrived to the emergency room excuse me, arrived to the operation room or arrived to the ICU. So we can have a sense of how much load of injury is inside that school, additionally to the primary injury that you see in the CT. Because we regularly see the CT and we imagine what is happening there, but we don't have any kind of measurement of what is happening there. And we all know that there are many variations. We have patients with hematomas that have normal ICP waveform, you know, and we have patients with a small, very small contusion or sometimes small subarachnoidal hemorrhage that have a total abnormal ICP waveform. So every patient have their own manage of their compliance. We have been going over details. I don't want to extend too much my conversation here, but we are going over details. And for example, in this type of patient that we have evaluated and they have an abnormal ICP waveform with very small lesions, when we operate these patients, because most of these patients goes over invasive monitoring and we decide to take that early to surgery, we saw, for example, that the dimensions of the cranial bone are the double of the regular one. So when we measure, and you never think about measuring the type of the bone in the cranial bolt, you know. So we have been seeing that regularly. If you measure the cranial bone at the cranial bolt level, is around 1.5 centimeters in wide. But we have patients that sometimes when we take that to the operation room, they have 3 centimeters, 3.5 centimeters. So if you have the double of the size of the bone, you will decrease your compliance at least 50%. So we just have, with minimal injuries, you have more affection of the compliance. So there are so many aspects that are associated to this, and it's opening an interesting space into the TBI analysis.
Oh, thank you. Very, very well explained. Hope you can extend this explanation later in IKRAN in Surabaya. See you there. Thank you. Thank you.
Okay, see you there.
Thank you very much.
Thank you, Dr. Ali Ayas. Professor Pirazada from Afghanistan, do you have some question?
Hello. Salam alaikum. Konnichiwa. Greeting. Thank you, Professor Rubiano, for your presentation and this iconic consensus. But unfortunately, in Afghanistan, we haven't the possibility of Doppler ultrasound and also is impossible, you know, but here is in Afghanistan is limited resources, and unfortunately we haven't neuromonitoring and what's your advice for us? And that's how to is it possible for papillometry? And also you mentioned about in November conference or congress. Is it possible to share the links and send us about this congress or conference? We are interested as well. Thank you.
Thank you so much. Very kind words, and salam alaikum too. Really nice to meet you. And hopefully soon we can have spaces to discuss. And definitely, I think many of these systems will be available in most regions of the world soon. as you mentioned, from the 4 systems, the TCD is the most complicated one. The pupillometry is very easy. The non-invasive system analyzer is a software, so it's pretty easy also. And I think more and more frequently, the optic nerve ultrasound can be performed with systems that are of very low cost. I know, for example, that in China, there are linear probes that are connected by Bluetooth. You can connect that through your cell phone, or you can connect that through a tablet. And it's pretty easy. We use in our center, we use Bluetooth ultrasounds that can be connected to the cell phone and allow us to measure the optic nerve diameter. So I think all these systems will become soon very accessible for many of the countries.
Thank you. Thank you very much.
There's another question. Some people said, thank you for the lecture. However, what's the cost implication for such a procedure? The limited field of vision intraoperation in comparison to an open approach. Some people ask a question.
Okay, thank you. No, totally. I'm totally agree. If you have a reduced vision space, you will have more possible complications. But I think the key aspect is when to perform the procedure. It's not how to perform it, it's when to perform it. Because the idea is that if a patient have, implications and have an abnormal compliance, and you don't have too many resources, as we mentioned, maybe you go better for an open approach and prepare the patient for any kind of complication. So I think the minimal invasive ones are more reserved for areas that have the possibility of measure early the compliance and understand that that patient with any kind of primary injury that they have do not have problems with the compliance. So you act quickly with a non-invasive system, or minimal invasive approach, excuse me, or if you have a lot of technology and you can perform a minimal invasive procedure and evaluate if a patient will require a more open procedure after that. So I think that will be the key aspect is when to really patients beneficiate for this type of procedures.
Yes, I agree with you. Actually, in my neurosurgery center, every year we have the 7,000 operations and 4,000 provisional therapy in my neurosurgery center. We have the endoscopy, intravisional, CT, intravisional MRI. Yeah. From our experience, no matter invasive operation or open approach, it's okay. Maybe it depends on patient's situation. There's no flex model. It depends on patient operation. Yeah, maybe something is very serious. We should use the open approach. It's maybe the chronic, we can use the chronic, the patient is not serious, we can use the invasive. Other people ask a question?
Yes, if I may ask, Prof. Andres, first of all, let me thank you for this wonderful lecture, extensive, of course, but we learned a lot. I just wanted to ask you that you yourself have published about usage of external lumbar drain for refractory intracranial hypertension. So there are several other centers in the world that have used this, even with in the Charité Berlin, where Prof. Vatkozzi has used it, and they have found very good results with the external lumbar drainage. So why is not everybody going through this, investigating this? Only one randomized control trial which is currently going on, which is the elastic trial. We're all waiting for the results. So how often do you use it in your clinical practice?
Thank you, Raya, because I think this is a very important issue. And I think according to one of the early discussions that we have, if you compare physiologically, the lumbar drainage will behave a little bit more like the cisternostomy than like the ventriculostomy. So the main issue with the lumbar drainage is that we all know that in some patients can have risk of herniation, especially if they do not control that very well, very specific. And I think it's totally dependent of the team that you have around. Um, we use it sometimes in some cases. Um, we have been with cases that because do not have a strict control of the drainage, sometimes can present complications totally associated to the drainage. So I think it's a useful tool when you already have detect or perform all these other procedures, not working as an isolated procedure for the management. It will be a coadjuvant. And also needs to be associated with the evaluation of the compliance and the impact that all the primary injuries have over the compliance of the patient. So it's very tailored. If you see the main message of many of the discussion is that we are moving, we are shifting paradigms here. We are moving to the regular last 50 years of work with these patients is that we have protocols or guidelines that try to work for all the patients. We now understand that every patient manage their own response to the primary injury, and we need to understand how that response is being performed and how can we support the patient in order to avoid complications during the evolution of the secondary injury after the initial trauma. So we are definitely opening a space for personalized and precision medicine in TBI. You know, we now have precision medicine and personalized medicine for neuro-oncology, neurovascular. So why not take this to the TBI area? I think we are in the process now of moving to that direction.
Thank you.
I saw on the clipboard, some people say thanks for Professor Azmi. Well, I think as a patient, yeah, thanks for Professor Azmi. Good remarkable positive result for the patient. Is there some people to ask a question? Some comments?
Maybe can I have a very quick remark about comment, and thank you, Professor 𝑑𝒓𝒐𝒏𝒈, for your great lecture. Give me very insights, and I do hope in the future, like the flank and also the ACNS and with your trauma, that we can have more events together, so we can meet you to discuss about the trend, because the trend is in trauma is moving very fast. I have only one short question is about what is your view towards the biochemical markers in TBI? So because currently is a very hot trend. So what is your view on this?
Okay, I think that's the next step that will be associated to everything that we discussed today. Is that if you can imagine that since the emergency department, we understand how the compliance is associated to the primary injury. And then you have the possibility of having biomarkers level in order to understand if the severity associated to the loss of compliance is also affecting the biomarker response. We are gonna have the last stage of the precision approach for this type of patients. And we all know that I think this year is gonna be published the new proposal for how to classify the patients with TBI. We will be moving from the a standard GCS approach to a more integrated approach, not only based on the GCS, but also based on the biomarker level, and also based in some other conditions, and a more deeper analysis of the image. As I mentioned, there are some proposals like the British classification of the primary injury. So definitely, I think we are in an era that we will see a lot of changes in order to how we take decisions and the decision-making process with the TBI patients. And we will understand very early if we are in front of a patient that will require more aggressive management, and we will not be in capacity of bringing that, or if we are going to be in capacity of bringing that. And we will be also in the face of a patient that we will understand that independent of how the GCS is behaving and how the CT looks, the amount of load of injury is not that big, and we will have the opportunity of being not too aggressive because that patient will be working only with that approach. So I think that's a very important aspect that you mentioned, and the biomarker will add a lot of additional information for decision making in this patient.
Thank you so much. So I think there is no more questions on the forum. And maybe Fem, can you I know that you also work with the first of all, any comments from you, and if not, maybe it's time that you can introduce about the Danon ISMIN Congress.
Thank you very much, Professor, for inspiring lectures. I learned a lot. And I will talk a little on the conference that we, the Vietnam Neurosurgery Society and ISMIN organized in the end of this year. This is a conference in conjunction between the 24th Vietnam Neurosurgery Conference and the 9th ISMINS conference. It will be held in a big city of Vietnam, in Da Nang. You can see the map here in a central region of Vietnam, with the theme of minimally invasive but maximally effective. The conference will cover minimally invasive surgery to diverse areas of neurosurgery, including vascular, brain tumor, and so on. So the time will be in 7, 8, 9 of November. We will have one pre-conference workshop and 2 other later days of presentations. The city of Da Nang is a big city of Vietnam, so it has a very extensive connecting international flights to the other major cities in Asia. So it would be efficient for you to travel to. And the city is also a very good place for traveling as well, with a lot of tourism with spectacular sightseeing as well. So you are welcome to Da Nang in the end of this year, and attending the one of the most interesting conference in Asia, I think. Thank you very much.
Thank you so much, Fan. So is there any comments from the floor? So if not, shall I invite Professor Kato for your final remarks?
Thank you very much. Thank you, Dr. Miano. It was an excellent talk. I think the neurotrauma is, I think, one of the most difficult field to treat, I think, because you mentioned so many times in your lectures of theoretical analysis, and also, of course, the CSF circulation or ISP control, and also the timing. So many factors. So I think it's quite difficult. And most of the treatment done by the young neurosurgeons, so they should know the maybe such kind of the theory or knowledge. It's very, very important, I think. Anyway, thank you very much. So please continue the teachers. So we learned a lot from your lecture. Thanks so much. And today also we had a great the 2 talks. So maybe we learned a lot. So maybe the next time, maybe Dr. Azmi will think about another new nice session, I think. Okay, so thank you very much.
Thank you so
Thank
much.
you, Professor.
Professor Priestley, you have a final remark?
Yes, just I'd like to say Happy Women's Day for Professor Kato and all of ACNS. Happy Women's Day. For
Women's
our-
Day.
Women's Day.
Yes,
It
yes.
was
Women's Day.
Happy
Okay,
Women's Day.
okay.
Okay,
Okay,
Happy
thanks.
Women's Day. Yes,
Thank you. Thank you so much.
thank you.
Thank you.
Thank you
Okay,
so
thank
much.
you, everyone.
Okay, bye.
See you
Thank
next
so
time.
much.
Bye-bye.
See you.
Thank you so much and for joining. Thank you.
Arigato gozaimasu.
Yes, thank you so much.
Arigato.